question.
Like to start with the question. The other day I had a young woman, 45 years old, something like that. Oligocystic lesion, 5.5 times 4 centimeters, small ball, scar in the middle, no nodules. The scar was a little perfused on Doppler sonography. We did a fine needle aspiration. CA negative, amylase negative, cytology not malignant, so serious cystic neoplasia. But the size alone, 5 centimeters, would, if you look at Sendai, I think, suggest that you resect it. Should we resect it?
Not at all. No, well, the first question is there an additional dilation of the main duct?
No connection.
And if this is not the case, and with all the data you just mentioned, it is almost 100% that it's a serous lesion, and then it's almost 100% that it's benign. So you can tell the patient you don't need surgery. The Sendai guidelines are for mucinous. So you can actually say this is a cystic lesion that is not meant to be treated according to Sendai. So I would not resect it. I would even not do any more tests. Just forget it. As long as it's not symptomatic.
Yes, for the large serocystic neoplasm, like you mentioned, the size, the big size, we have some patients with compression of adjacent organs and symptoms related to compression. Then you indeed propose surgery only for symptomatic patients in case of large serocystic neoplasm.
Is there any use to do molecular biology?
Sorry?
Additional analyses, molecular biology?
No additional analysis. In asymptomatic patient, I agree totally with my colleague. No other examination.
My question goes in the right direction. I mean, as gastroenterologists, we do a lot of endosonographies, we do a lot of punctures, but at the end, the question is, how can we really be sure that we diagnose in the right direction? So can we really see the subtypes? Can we do more testings, like not only CA, but can we do mucin levels? Is that good for the diagnosis? So for what we now started to do is cytoblocks. So we do centrifuge the cells and the mucus or the fluids to try to do blocks in formaldehyde. Is that something we could go in the future?
Yes and no. So yes, in the sense that, of course, if you have the cell block, everything is compacted, so it is processed then like tissue. And then you can do all immunostaining, so you can do subtypization. On the other side, you have some disadvantage from the molecular point of view, because it's formalin fixed, it's not more alcohol fixed like the cytology specimen, so you might have problem for molecular analysis, which I think alone, of course, it has no meaning, so I would never rely on some molecular result alone. It has to fit to morphology, it has to fit to other data like CA level, clinical, and imaging data. So unfortunately, there is no clear answer. You have to see case by case if cell block or if it's possible to keep something alcohol fixed and some part doing the cell block. This depends, of course, always on the amount of material you get.
And can you also again discuss the mucin staining? Is that an advantage?
Yes, I mean we use it routinely, and we do it. This is some very easy stain, and we see if there is mucin or not. So it's very useful in the classification. There can be false positive results.
And the subtypes of the mucin?
This is with the no. I wouldn't rely on this.
John, please. Thank you very much. 3 great talks. I've got a question about the molecular pathology. So there seem to be some fairly common patterns to the RAS mutations, and I wonder if that's coincidence or there's some meaning to the type of RAS mutations that you occur. There are various types, and also there was a comment made about microRNA. Does that help you distinguish malignant from non-malignant, for example?
For KRAS, the answer is unfortunately not. So no. So there are these mutations, but frequently the frequent mutations are those that you also find in ductal adenocarcinoma. So it's not. I wouldn't rely on these, and unfortunately they are present also in early lesions, so they do not really correlate with malignancy. For the microRNA, there are first studies showing that there is some profiling, so some combination of microRNA that can that associate with high-grade lesions in IPMN. So it is the beginning of that, of course, but it can develop in this.
Thank you.
My name is Stefan Stetter from Innsbruck. I have a practical question. Doing biochemistry analysis is very helpful sometimes, sometimes not, but we realized that if it's very mucinous, then the lab said they can't do any biochemistry analysis. So what is your experience on that? Are there any tricks to overcome this problem?
When the biochemical analysis is not conclusive and
it's not working because it's too the
yes,
mucus
we have
is just
sometimes some. Then we try to identify by imaging procedure morphological characteristic, and we go eventually to surgery when there is some high-risk stigmata of a mural nodule, and
then you have
then
to use the other tools. But okay.
Sorry.
I have a comment about your preference about the guidelines. The Sendai 2012 are validated, but in all the validation series, always we have a very low positive predictive value, around 20 to 30%, and not a 100 negative predictive value. Then it is very, very difficult. And when you follow the cyst, the branch duct cystic lesion, the supposed branch duct IPMN, then even if we have an increase in the size and appearance, the rate of malignancy in these patients operated because they are progressed is not very high. Then it's very, very difficult to choose the correct guidelines, I think. And there is discrepancy with the American who stopped surveillance. If there is no change after 5 years, they stopped the surveillance of the cystic lesion.
Yeah, please. Well, I fully agree. We have not a guideline that is what we really want, but it helps at least. And the question is really, do we want to wait and say, okay, at least we do no harm with an overtreatment, but then we accept that we have some patients that we have seen and we could have treated, and in the end they come back with a cancer. So it's always the balance between. And it's a question of which patients to choose. And what these series that I showed tell us is that some experienced clinicians, pancreatic surgical centers, they obviously choose quite well because they have such a high rate of malignancy in the resected specimens. So that means it's not bad what they do. But of course, pancreatic surgery is risky. That remains at the end of the day, and we don't want to lose patients for prophylactic surgery. So this dilemma is out there, and we have no answer so far.
Luciano?
Thank you to all speakers. The lectures were really of high standard. But when science meets practice, this has lots of problems. Currently, we have 4 weeks from diagnosis of suspected malignancy in pancreas to making a clinical decision in Poland. Because we have legal act which says you have 4 weeks to make decision. This patient is potentially cancerous patient and should go for surgery, or we should stop the early cancer detection program. The mucinous lesions are not typical, which should go to this program, but actually in practice they do. So what we do typical workout, meaning the imaging, EOS, and then there is moment of decision to close the program for this patient and observe, or to go for surgery. Very often we simply at the end sit in front of patient and discuss. We are not completely certain of your malignancy risk. We would like to observe it, but decision is yours. How often in your practice, after typical workout, you sit in front of patient and ask him for decision, observe or go for surgery? And what kind of patients these are? Thank you.
I think it would be unfair if I just burden the decision to the patient. So I keep this with me. But of course, I discuss it with the patient, showing him advantages and disadvantages. It really depends on the case. If I have a 3 centimeter side branch IPNN in the center of the pancreas, I go for middle segment resection because I can tell the patient, in the worst case, there is maybe a pancreatic fistula grade B or very rarely more. So maybe this is of course not what we want, but this is not dangerous. But if the same lesion is in the uncinate process, I would say we better wait a little longer and have another look. And if it continues to grow, then maybe it's justified to take the risk. So I clearly say to the patients what I think is best for them, and I just think, what would I do with my relatives in this situation, knowing the data that we have, and knowing that maybe in some decisions I'm wrong, but that's how I would answer your question.
Another point also to take into account is the familial history. We have some patients from family with a large number of patients with cystic lesion. In these patients, they are more prone to develop the IPMN and maybe with malignant potential. These patients are also different from the first case in a family.
I mean, since we have still some time left, I would like to discuss this even a little bit more. So since we have the MRI now, and nearly everybody after the age of 60 gets an MRI, and many of our patients have Sendai negative branch duct IPMN in the CT or MRI. It's really a huge discussion in our tumor conferences. What is the follow-up in the patients? How can we go on? So my question, of course, is even if we don't have a radiologist in the podium, shall we go for endosonography or for MRI or for CT scan? So what would be the typical follow-up?
Yes, according to the most recent guidelines, the follow-up proposed is by MRI every 1 time a year for 2 years, and then if there is no change, 1 time at 5 years, and then you stop following. Maybe it's not so bad because even in the surgical series, more than half of the resected lesions are benign. More than half, then it's very high rate. And maybe it's to decrease the number of invasive procedures like AOS, and to decrease the cost of the surveillance also, and to, if possible, increase the positive predictive value of detection.
But still, if you say half of the resected lesions are benign, the other half is potentially growing into cancer, and this half I saved with the surgery. So this is yes, why I think we really have to think about performing surgery more often. But again, we have to choose well.
The same problem is actually the case for the main duct IPMN, right? It's not always malignant. And if I remember well, there was just recently a paper from Asia, some 200 patients with limited main duct IPMN surveyed for years, and I think they had an operation rate at the end of less than 20% or so. So there seems to be a population which does not necessarily progress to malignancy. Can we identify this? Now, it's clear, you know, the criteria right now is operate them, and we would do that. But is there something in the future where we would hesitate and say maybe even a main duct IPMN can be observed?
As for now, there is no data. So I would go for it. The question, and that is very difficult, is how much to resect. If I have the cystic lesion in the head, the main duct is dilated far to the left. So there are some proponents saying, of course, this needs total pancreatectomy. I'm not sure. I would just do a resection of the head, ask the pathologist how is the resection margin, and then wait. But basically, we have no hard evidence to do either the one or the other.
And biopsy does not help, right? Because it's easy to biopsy a main duct IPMN.
Yes, so far, as I said, there can always be the problem of the sampling error. So you can biopsy, but then you still don't know if it is benign or malignant. Maybe. So the extent of resection is an issue, especially in not invasive IPMN, because if there is some cancer then and you have low-grade IPMN at the margin, you can just leave it and stop it there, because the prognosis is the one of the invasive cancer. If it's not invasive, then you try to obtain free margin. I think this is what we suggest, at least.
Maybe just to follow this question, I would like to ask Mrs. Esposito just to tell us a bit more about molecular biology. What are at the moment what is the status of the research? Where are the researchers looking at? Because probably part of the answer, not all, of course, but a part would be there.
Yes, I think so. The ideal thing is a panel. It has also been recently published, I think in Gastroenterology or something like this, with the genes that I've shown in my talk that are quite characteristic of the different entities, so that on the cyst fluid or on the smears, you can also take the smears, you perform this test, this panel, and this can aid in the diagnosis. So, for example, in the case of the young patient there, I would be curious to see, for example, is there some VHL, or maybe it is a mucinous. I don't know if it was in the head or in the body tail of the pancreas. So it could still be some MCN in the end. So so a panel of changes, and these are those GNAS, RNF3, RNF43, VHL, and of course KRAS, and some other that are known to be associated with the malignancy. And we are going to develop this and to do it on the cyst fluid and on cystic lesion of the pancreas. I think so. Pathologists should go in this direction, always being careful that a molecular test can never be a substitute of clinic imaging or morphology.
Thank you. Maybe the last question, Lucian.
Really good summary. As yesterday we discussed, the registries, they are good if they cover the whole practice. Maybe it's high time to provide a prospective registry of clinical workout and clinical decision and final outcome that will observe few hundreds of patients and will make the same workup for these patients. And we will register what was done. We observed the patient for 5 years, nothing happened. We treated the patient surgically, and this was the mortality or morbidity of the surgery. And the final outcome is that patient was alive after 5 years. Because at this moment, in maybe referral, but not highest level of referral centers, we will know what to do. At this moment, we can either follow Japanese or American standards and we can hear from the experts that they do something in between still. Thank you.
Well, there is a project on the way establishing exactly this kind of data.
What's that?
So the European Gastroenterology Association and European Digestive Surgery, we already had some meetings, and there are several gastroenterologists and surgeons interested in cystic lesions. We are putting together a protocol to just put these data together.
And you include molecular?
Whatever comes.
Molecular.
Yes, whatever comes up, whatever we can include, we like to include.
We are going to close the session. Thanks the speaker for the great talk and the audience and the speaker for the discussion. And it's time to coffee break.
And thank you for your participation.